Okay, so let's start on the electrolyte disorders. Okay, so if we have hypovolemia, that is when we're going to have basically low volume. And so the ECF is going to be reduced and it can lead to hypotension and shock. I like to think about that water follows electrolytes. So if we have low volume, it's usually because of salt and water losses. If we have too much volume, hypervolemia, there's probably too much sodium, which is the main solute. And there's going to be expansion of the blood volume, and it can lead to hypertension. Okay, so the body regulates this through osmoreceptors, like that release ADH or vasopressin, which is basically the same thing. And then the osmolality changes. Arterial baroreceptors are triggered to release the ADH when the volume decreases in our blood and when the hypovolemia is sensed. The RAAS system also helps with this. And then we also have ANP and BNP. And I think we'll talk about that in a little bit. Okay. So the medullary system, that in the interstitium, it must be hypertonic because, again, water follows solutes. If there's not enough solutes to create that hypertonic interstitium, then water can't be reabsorbed, and then we lose the water that we need. Okay, it's important to know the difference between osmolality and tenacity. And it's kind of confusing, but the main difference to know is that tenacity reflects the concentration of the solutes that don't cross the cell membrane that easily. So mostly sodium salts. Most of the time you're going to probably talk about the osmolality, but sometimes you need to talk about the tenacity. So this is just a slide that gives you the definitions of both and the difference. So looking at the osmolality, we've got this measure of the body's water to electrolytes that can be, you can look at it through this equation. Now, don't memorize the equation or anything like that. But if we take the measured minus our calculated, we have the osmolar gap. Here is our diagram again, just looking at that and remembering it. And so right here is our osmolar gap. So we would get, after we get our HAGMA, then we calculate our delta delta. Remember, so we have a high anion gap. We've got metabolic acidosis, got high anion gap. So we're going to calculate a delta delta and then also the osmolar gap. So if you're hypertonic, then most likely you're going to have low volume. And then if you're hypertonic, if there's a hypertonic solution, then it might be hyperosmotic. Let's look at an example in heart failure. So the heart might fail due to long-standing hypertension, a heart attack, left ventricular hypertrophy, just basically an issue in the heart over time, and the fluid is not being able to be pumped, so it starts backing up. So in the clinic, you may see patients with really big legs and that has pitting edema. So this is an example of hyperkalemia, but the actual volume is not in there, or is in the interstitial space. It's not in our cell. It's not going to be in our plasma, but it's like right here in between, in the tissues. So since the fluid's lost, our RAAS is going to increase because it's saying, hey, like there's, something going on, like we need to get this to work out, and it's constantly going through a cycle. So volume overload, we've got JVD, edema, pulmonary crackles, orthopnea, which is the shortness of breath when lying down. And then wake up suddenly short of breath, that's paroxysmal nocturnal dyspnea. And then also, if it's volume depleted, we've got decreased turgor, dry mouth, dizziness, or low to no urine output. So know that changes in serum osmolality are usually caused by sodium abnormalities. Okay, so here's looking at ADH or vasopressin. So remember, ADH is made in the hypothalamus and released by the posterior pituitary, which tells the kidneys that at the kidneys, it's released at the distal convoluted, or at the convoluted tubules, and it causes the aquaporin channels to take in more water. Okay, so SIADH. So basically, we've got too much ADH. So too much is causing the fluid to be reabsorbed. So the serum osmolality is going to be hypotonic, but the urine will be hypoosmotic is the serum. The urine is hyperosmotic. So basically, the way I think about this is, if a person has like ADH is going to make you sort of like dries you out. It makes you reabsorb all the water. So your urine is going to be really concentrated. And so if it's really concentrated, it's going to have high sodium in it, and it's going to be hyperosmotic because it's really concentrated. Your blood is going to be like super dilute. So we're going to have low sodium because we've got so much water, because the ADH is increased too much, and so it'll be hypoosmotic. Diabetes insipidus is the opposite, pretty much. There's two types. There's going to be central and nephrogenic. I would make sure I would know the difference between those two. I know that you've covered that before in physio, but it's either that there is not enough ADH or there's not a good response. So I sort of think of diabetes insipidus, central diabetes insipidus, is a problem with the brain. So I think of that kind of like how there's two types of like diabetes mellitus. I know it's not the same, like don't get too confused, but like type 1 diabetes is a problem of the pancreas itself at the beta islet cells. But type 2 diabetes is like a insulin insensitivity. You have enough insulin, but it's just not working at the cells itself, can't accept it in. Same thing with diabetes insipidus. Central diabetes insipidus, central meaning head. So we've got a brain issue, so we can't make ADH. Nephrogenic diabetes insipidus is going to be the aquaporin cells, like we have ADH, but we can't accept it into our cells. So the serum osmolality is going to be super concentrated, hyperosmotic. The urine osmolality is going to be hypo. So these people pee all the time, and they're going to like get up several times at night to go to the bathroom. They're going to be constantly thirsty and constantly drinking water, but they're going to have really dilute urine. It'll look pretty much like water, and pretty much all it is. And so, but they'll be peeing a lot. So basically, so it's like, so I think of it that way. So it's pretty easy if you remember either SIADH or diabetes insipidus. Remember one of them, and then like just know the other one's the opposite. That's how I remember it. Know that chronic lithium use causes induced resistance to ADH, and it may not resolve. So know that that goes along, lithium goes along with nephrogenic diabetes insipidus. And we've got a whole slide here, so probably good to know. Looking at it again, SIADH versus DI. If you have any questions, please ask me. Okay, primary polydipsia. So this is like the psychogenic polydipsia is another way of saying it. And so basically the patient just drinks too much water and they can like physically drink themselves to death. So it's going to look really similar in a way to DI, but it's also going to be sort of similar to SIADH, but it's not going to look like either. And so let me explain what I mean by that. So if a patient drinks a ton of water, regardless of their thirst mechanism, the serum osmolality is going to be low. So that sounds more like SIADH. However, the urine osmolality is also low. That's kind of like our diabetes insipidus. So they're diluting everything. So their body is trying to concentrate, but it's having a hard time because there's so much water coming in. It can also be caused by other things like pregnancy, hypercalcemia, hypokalemia. So don't always think it's like a psych issue. So knowing this water deprivation test is important. So what happens is the patient comes in and they're like peeing a lot and thirsty and everything. And it's a lot of volume every time. That's important to know, not just like dribbling. And you take a urine and you check the osmolality. So a normal person is going to have about 500 or more. And at that time, when they start the test, you tell them to stop drinking water. So time goes on, and with diabetes insipidus, the urine osmolality is going to be really low. So that's because it's super dilute. With time, a normal person is going to increase their osmolality, so it's going to become more concentrated. Central diabetes insipidus or nephrogenic, it's not going to change. With psychogenic polydipsia or primary polydipsia, it's going to increase. So it started out really dilute, but then it's going to increase over time because they stopped drinking. They've like stopped their problem. If you give someone ADH, which AVP is just the brand name. So you give them ADH or desmopressin, same thing, that's the drug name. At that point, you can distinguish between central diabetes insipidus and nephrogenic. Remember, nephrogenic, it is a problem with our receptors. We have enough ADH. So their osmolality is not going to change. So they're still going to be really dilute. With central DI, you've literally fixed their problem. They didn't have any ADH to begin with. So now their osmolality of their urine is going to go up. Now they can concentrate their urine. So now you've got a test. So looking at this, and you've got access to it, it's got all of basically the answers, if it's serum or urine, and then the water deprivation results, as well as the exogenous ADH for normal person, SIADH, dehydration, nephrogenic, central DI, and then primary polydipsia. And then just the line means it doesn't matter. The crossed out means none, basically. Okay. So now let's get into the electrolytes. So we have hyponatremia, so that means low sodium, which is defined less than 135. Don't worry, you're always going to be given ranges. And this is caused by SIADH, diuretics, vomiting, diarrhea, or kidney disease. And so we're going to treat our hyponatremia with fluids that have sodium in them. Osmotic saline would be one of them, 3%. Normal saline is going to be 0.9, and then hypoosmotic is 0.45. So we don't want to overcorrect really quickly because that's going to lead to osmotic demyelination syndrome. So the way I remember it, it's from first aid. Low to high, pawns will die. High to low, brain will blow. So anyways, that's the way you can remember it, but that's just changing sodium. That's what that whole thing is. So this is sort of interesting, and you don't need to know this, but it's like a good thing to think of. So normal saline is 0.9%, and normal saline has 154 mil equivalents per milliliter of sodium. So if my sodium, let's just say, is 130, if I'm giving 154, that is already way over the number that I need. So you don't always have to give them that 3%. So the normal saline is pretty salty as is. So it's just important to not overcorrect. Okay. Hypernatremia is over 145, and causes could be dehydration, free water loss, diabetes insipidus, burns, salt poisoning, and too much normal saline or hypertonic saline. Because like I said, 154 for normal saline. So treatment is going to be half normal saline, like you might hear it called that, and that's just 0.45, or D5 water, which is dextrose. Okay, so here's our osmotic demyelination. And so this is from his article, but basically just know that this is really all I would know probably for the test, but is that rapid correction of hyponatremia can cause this demyelination syndrome, which hurts the pons with this uncal herniation. Okay, lecture 8. The RAAS system. Okay, so we've got hypokalemia, which is less than 3.5. So our main causes are going to be acid-base change, diuretics, extrarenal losses, vomiting, diarrhea, or decreased dietary intake. So our symptoms are going to be muscle cramps, QT prolongation, torsades, and there might be a U wave present. So things influencing potassium. I think it's easier in my mind to think of it as like as far as drugs. So our ACE inhibitors and ARBs, they can increase our potassium, and then our potassium sparing agents like spironolactone. So things that affect it: aldosterone, distal tubular sodium concentration. So our sodium concentration can change our potassium as well. Our tubular flow rate, high tubular potassium concentrations, and then metabolic alkalosis. So check for hypokalemia. If a patient already has hypokalemia, it is good to also check a spot urine for urinary potassium. And look at their urinary potassium creatinine ratio to help you determine, are they getting rid of potassium in their urine, or is it another cause? So this should probably say check for cause of hypokalemia through a spot urine. Okay. So here again, same thing. Looking at some implications for changes in our potassium. So our potassium creatinine ratio, if it's high, it could be then we need to look at the blood pressure. If it's high, it'd be like kidney or like some of these issues. There's lots of issues, but I wouldn't like worry too much about it. It's just like something to know. Okay, Liddle syndrome. So this is at the ENaC channel, and it's where it's constitutively turned on all the time. So this patient is going to have hypertension and hypokalemia, and the RAAS system is going to be turned off. So they'll have low renin and low aldosterone. Okay, so looking at this is like the best way, I think, to remember what these look like. So we've got like Liddle syndrome, Barter, Giltman, renal tubular acidosis, and really like remembering these, just like where they go. So like Barter syndrome is going to be like the loops. Gilman's going to be like the thiazides, and Liddle syndrome is going to be like the potassium sparing diuretics. Okay, hyperaldosteronism. So there's going to be a primary and secondary. Primary is going to be, and the way I remember like primary versus secondary is like anything, is that the primary action is going to be like the problem itself. So aldosterone. So aldosterone is going to be high. There's going to be a feedback mechanism where it'll give us low renin. Secondary is because we have high renin, and high renin is going to make high aldosterone. Okay. Hyperkalemia. It's going to be a potassium greater than 5.5, and it can cause arrhythmias. So pseudo-hyperkalemia is not actually hyperkalemia. The patient's fine, but your blood test says hyperkalemia. So when you get that, make sure that that your blood is not hemolyzed. And so when the blood cells break open, they're going to release potassium, and also it would decrease your glucose. So On an EKG, if a patient actually does have really high hyperkalemia, you may see T waves and increased PR intervals. So look for those T waves. I know that they love to test on that. Okay, so determinants of distal nephron secretion. We're going to have serum potassium, aldosterone, distal tubular sodium flow, pH, tubular flow, medications, and other etiologies. Okay, treatment. Make sure if somebody has hyperkalemia, like favorite answer that people say is that they're like, well, let's get it into the cell, let's give them insulin or a beta 2 agonist, but don't you do that. You first need to make sure that their heart is okay. So you give them calcium gluconate to stabilize myocardial cells. That's the first thing. And then now that your heart is stabilized, now you're going to get their potassium to go down. So you're going to give them insulin. And if you give a normal person insulin, I mean, really, if you give anybody insulin, their blood sugar is going to go down. So if instead we take the insulin, we don't want it to go down too far, so we're going to give it with some D50. So that way we're going to shift it into the cell, and then, but we're going to make sure that their blood sugar doesn't get too low. That's like the important thing to know. I would just make sure, like, first thing you do, give them calcium gluconate. Okay. So the difference is hypokalemia, probably like a flat T wave, small inverted, and a U wave. Hyperkalemia, tall tinted T wave. And that's like the rest of the summary. Okay, calcium. Okay, calcium is all about regulation, deals with calcitonin and PTH. Calcitonin tones down our serum calcium. PTH increases our serum calcium. Okay. Now, calcium is low. Our parathyroid glands are triggered to release PTH. PTH acts on the kidneys, on the intestines, and the bone to release calcium. So the kidney is going to reabsorb more. The intestine is going to absorb more. And then also the kidney is going to get rid of phosphate. So it takes in calcium, gets rid of phosphate. And then the calcium is going to go to the ECF from the bone, and we're going to reabsorb bone. The kidney and the kidney is going to activate vitamin D. So we've got vitamin D 125. I would know that one. The 125 vitamin D is going to be our active form of vitamin D, and that's going to work with the intestine. And that all goes to increase our calcium. Okay, so basically, again, calcium, lots of feedback loops. We went over that right here on the left. And so PTH is effectively going to increase our calcium and decrease our phosphate. Hypercalcemia, our symptoms, make sure, like, you know, all of these, is going to be our stone to bones groans, psychiatric overtones, and then we're going to have a shortened QT interval and muscle weakness. Actually, like, fun story, I saw a patient, she was there for a surgery consult, and it said on her records that she had schizophrenia in the past. And I was like, that's interesting, but she was on no schizophrenia meds, like no psych meds. So I walk in there and I'm like talking to her and stuff and, you know, asking about her history. And she tells me, oh, yeah, one time my calcium was really high. And she said, yeah, I went crazy. I didn't know what was going on. And they did some, I was talking out of my head and they did some blood work and found out that my calcium was high. So my thoughts is, I don't know if it's true, but she probably didn't have schizophrenia. They might have thought she had schizophrenia and diagnosed her with that, and then and maybe treated her at the time, and it was actually really high calcium, and they never took it out of the chart. So kind of interesting. So anyways, stones is going to be like kidney stones. That one's kind of make more sense. They're going to like hurt. Causes can be cancer. You'll talk about that more when you're in the endocrine class. Increased too much vitamin D. There was actually a patient not too long ago in the hospital, and she was taking her vitamin D incorrectly. So she was taking like a pill that you're supposed to take once a week. She was taking it every day. So she ended up in the hospital with hypercalcemia, hyperthyroidism, and thiazide. So the thyroid glands can release calcitonin to respond to the hypercalcemia and try to get it back down. So treatment for this one is going to be hydration, diuretics, like loops, and bisphosphonates. Hypocalcemia, we've got the muscle cramps, Chekhovec sign, Trousseau sign, weak brittle nails, QT prolongation, carpopedal spasm, and seizure. So Chekhovec sign is where they tap on the cheek and then they have a contraction. Trousseau is where they take a blood pressure and then their arm pops up because they're having like hypercontraction. So hypercalcemia, they're having weakness, hypocontraction. Hypocalcemia, they're contracting too much. I would know like carpopedal spasm, and that's like when the feet curls up. Okay, so hypoparathyroidism can cause it too little vitamin D or renal failure. So if we have too low calcium, our body's going to produce PTH to help go over it. In renal failure, you'll have low calcium and low phosphate because you're getting rid of everything basically. Phosphate. Renal disease is the major reason that you would have low phosphate. High phosphate is also if somebody has rhabdo or vitamin D deficient or too much vitamin D. Sorry. They're going to have very similar symptoms to hypocalcemia, muscle cramps, tetany, and so on. Hypophosphatemia, low phosphate, huge cause is refeeding syndrome. So a patient's not been eating malnourished, and you're giving them TPN or like you're giving them food through like an IV or something, or like a tube in their stomach, and they're not getting, or their phosphate is going to be driven down because they're not ready they've not been eating long enough. They don't have enough stores, and so other things are going up when phosphate is not, and so that they can have hypophosphatemia. So just know that it goes with refeeding syndrome. Okay. Now again, refeeding syndrome, hypophosphatemia. Make sure you know that. Okay, magnesium. So it's going to be essential, and it requires ATP. Hypermagnesium is going to be like flushing, headache, nausea, vomiting, neuro impairment. And a cause is going to be trauma, renal failure, burn, shock, sepsis, adrenal insufficiency. EKG changes. We've got too much magnesium, so long QT or prolonged PR wave. And then hypomagnesium is going to be weakness, exhaustion, hyperreflexia, and personality changes. So a big cause is malnutrition with this one. And so if the patient's not been eating a lot, they check a magnesium on them to see when they've to see where that's at. I probably know malnutrition for magnesium. So they're going to have the long QT and flat T waves. Barter and Gilman syndrome is going to go along with this as well. So here is our Barter, Gilman, and Liddle syndrome. Right out of first aid, I think that this is kind of helpful. So Barter, again, looks like loops. Gilman's going to look like thiazides. Liddle looks sort of more like I don't really want to say the potassium sparing because we have Hypokalemia. So it's like if you didn't have that or didn't take it. Okay. So Gilman syndrome, we're going to have our low calcium. So we're going to have a positive Chekhovicz and Trousseau sign. And low magnesium. Here's our EKG changes. And you can see the prolonged PR, lengthened QT, and in our hypermagnesium versus low. And these have all of our EKG changes, which is pretty good. Okay, lecture 9, acid base with our electrolytes. Okay, we've got causes of HAGMA. Right here, again, our mud piles, methanouremia, DKA, lactic acidosis, ethylene glycol. I think that these are probably the most important ones to know. Okay, so lactic acidosis is a cause because lactic acid is negatively charged and it displaces our chloride. Usually, you'll see in sepsis, septic shock, you'll see a high lactic acidosis. Ketosis, famous one would be diabetic ketoacidosis, is going to have where there's hardly any insulin in the body and the glucose is going to be not absorbed by the cells. And so the ketones are negatively charged and displace the chloride. So know that it causes the absolute insulin deficiency with DKA. Remember, again, this has been like multiple slides. When we treat our when we treat DKA, we're giving them fluids. As we give them fluids, our chloride is going to increase. Remember, it had been displaced before, and it's going to evolve into, we're not going to have ketones as much anymore. It's going to evolve into the NAGMA. So he could ask you, once it's treated, what is it? And it's NAGMA. Okay. Ethylene glycol Loves that. No, it's a HAGMA. And also know that it can, it causes calcium oxalate crystals. It's found in antifreeze. That's probably like what that they would say. Methanol can be in windshield washer fluid, camp stove fuel, like wood alcohol. That's methanol. Here's just our review again. Looking at everything. Okay, the osmolar gap is a valuable tool. We talked about it a little bit. It's the difference between the serum osmolality and the calculated serum osmolality, with the normal being less than 10. Ethylene glycol has a very large, it can be 100 osmolar gap. That's probably all I would pretty much know about that one. It's high with ethylene glycol. Alcoholic ketoacidosis is going to be a common cause of our HAGMA because of the acetone is negatively charged, displacing fluoride like the rest of our HAGMAs. And there's going to be a large shift from NAD to NADH. Chronic alcohol use is going to result in some changes in our electrolytes. So we're going to have a low potassium, low magnesium, and low phosphate. So I would know probably those. Okay. The renal tubular acidosis, we've got type 1, type 2, and type 4. And I'm going to skip to another slide, but this is the good things that you need to know about this. So the only one that has a high urine pH is going to be our type 1, which is in our distal renal tubular. And I'll talk about why in just a second. Now, all of these are going to have a metabolic acidosis. So the blood is going to be acidic, but the urine may not be. The urine is going to be acidic in type 2 and type 4, but not in type 1. In type 1 and 2, it's going to have hypokalemia. Type 4 will have hyperkalemia. Okay, this is my favorite picture. So type 1 is going to happen right near the end, right before our collecting duct. So basically, we don't have time to secrete the acid, so we're going to have a high pH because there's no time to compensate. I sort of think of this as drugs too. So our type 1 and type 2 are going to be, I think of them as like, just like our diuretics. So I think, okay, it's sort of like a thiazide. So I'm going to have hypokalemia. So our type 1 and 2 are going to be potassium wasting. And then type 4 is potassium sparing. And it's going to have a low urine pH. And then type 2 will as well. Type 4 is just going to be dumping acid. It's right at the end. But just know pH higher than 5.5, type 1. Type 1 and 2 have the low potassium, and type 4 has high potassium. And then just know it goes 2, 1, 4. Proximal, distal, and then our collecting duct. Okay. RTA1, there's types. So I would know autoimmune disorders can go along with 1, as well as sickle cell. Type 2 is probably not as important to know. And then, but type 4, diabetic nephropathy, and then ACE and ARBs. That's probably the ones I would know. So there's going to be a pulmonary component to the acid-base function. So remember that, don't forget about that. So this slide that he had is just like to tell you that if you identify acid-base disorders, you can help figure out what their problem is. So I wouldn't like worry too much about this, and it's kind of confusing with the question. All right. Any questions? Okay. So I'm going to do a few practice questions, and then we're going to go over and look at our last PowerPoint. When there is a hypertonicity, the body acts by releasing what? Okay, we're going to end it. Okay, so good job. It's going to be ADH. So we're going to want to reabsorb more water. Okay, let's look at question 2. This is a 2-part question. Okay, so when am I going to calculate a urine anion gap? Is our first question. And then if it's positive, what is it going to distinguish? All right, so here's our results. So we're going to calculate a urine anion gap in the presence of a HAGMA. And if it is positive, it's going to help estimate urine ammonium concentration. So it's not going to be it's going to be a failure of the ammonium excretion. Go to question 3. Patient has a hyperosmotic urine and a decreased serum sodium. Which IV solution am I going to treat them with? And then if I have a hyperosmotic serum and an increased urine sodium, what IV solution would I treat them with? Few more seconds. Okay. So we're going to treat a patient with a hyperosmotic urine. So that's going to be diluted, and decreased serum sodium. So they're going to have a dilute blood. So that's sort of like SIADH. We're going to treat them with hypertonic solution. Here's the opposite. It's our diabetes insipidus. So we're going to treat them with a hypotonic solution. Okay, let's look at question 4. Silly Susie came into the EV not feeling great. You got her pH, PCO2, and bicarb, but you forgot your computer password to read them. You do remember she has a high lactic acid. What's her diagnosis? So I'm doing this to show you that even if we don't have a pH, CO2, or bicarb, we can still answer this question. So what is a high lactic acid? Okay, so lactic acidosis is going to go with our HAGMA. So we've got a similar question, question 5. Jolly Jordan came into the ED, not feeling so jolly. You got his pH, CO2, and bicarb, sodium, and chloride, but forgot your glasses this time to read them. You got his pH, he's got a lot of diarrhea, and you suspect that you are dealing with what? Diarrhea. Okay, good job. It's going to be a NAGMA. Okay. Go to the next PowerPoint. Okay, this one is going to be the Pharm one. Okay. So I actually included the hypertension one as well. So it's actually part of your cardio class. I just included it in here, but we're just going to skip it. I guess we could go through it. Not like it's going to be too long. Well, maybe. We'll skip it and we'll go to the other lecture. Like I did last year, I included some extra stuff in here about what I thought would be important in red, and this are like my little Pharm guides. This is just a review of hypertension. This is what I would know from them. We'll just go over that part. We have our ABCDs of antihypertensives. Our preferred combos are going to be ACE inhibitors or ARBs with our calcium channel blockers, or an ACE inhibitor ARB with a diuretic. Things safe in pregnancy are going to be methyl-dopa, which is an alpha-2 agonist, or labetalol, which is alpha-1 beta-1. In elderly patients, it's usually just going to be isolated systolic hypertension, so I would know to use amlodipine nifedipine first, and then you can add an ACE or ARB if it's just systolic hypertension, not diastolic. In African Americans, they have a low renin pattern, so they're going to be less responsive to ACE and ARB, so use thiazides or calcium channel blockers like amlodipine nifedipine. If they are a white male or female less than 60, start with your ACE and ARB. If it's still bad, add it, calcium channel blocker or thiazide. If the blood pressure is already, to begin with, starts at 160 over 100 or higher, then go ahead and add the calcium channel blocker thiazide. And then add all three if it's still bad. Always, before you do anything, start with lifestyle changes. And make sure you check a blood pressure, more than one blood pressure, to be able to diagnose hypertension. And so here's some like contraindications for some of this stuff. Here's our direct renin inhibitors, our ACE and our ARB. Avoid our ACE inhibitors in our renal artery stenosis. Know that it can raise our potassium, and it's not good in pregnancy as well. If a patient is on an ACE inhibitor and they develop a cough, this could be due to the increase in bradykinin, which causes vasodilation, and also it can cause the swelling of the lips and tongue. That's angioedema, so they would need to stop that as well. So if that is the case, we would switch them to an ARB. Our problems are similar: hyperkalemia, hypotension. They don't get that cough or angioedema with ARBs. But it also constricts that efferent. It's also going to work to prevent the normal autoregulation of GFR. So it's so do not use in renal artery stenosis. Beta blockers. They are decreasing our heart rate, contractility, and our cardiac output. It could cause rebound hypertension or heart block. You can't use it in COPD due to that beta 2, the blockade, or in asthma. So I would like know that, and then don't use in peripheral artery disease. Calcium channel blockers prevents calcium from going to the AV-SA node. Decreases heart rate and cardiac output. And also that is our VDs, and then our DHPs are going to decrease our SVR. Alpha antagonists are going to work on the arterioles more than the venules. And so remember, labetalol is used in hypertension, pregnancy, or emergency. Alpha 2 agonists are going to directly act on it's going to be a direct intervention and circulating regulator. We're going to treat our, I'm going to skip diuretics and go over here. We're going to treat our hypertensive emergencies with our IPINs, DHP, calcium channel blockers, and it's going to peripherally vasodilate and then also give them sodium nitroprusside to increase our preload and decrease our afterload, and then labetalol can be used. Okay, our diuretics, we've got our thiazides, loops, and our potassium sparing. Thiazides, thiazides and loops are going to get rid of potassium, but our thiazides can cause hypercalcemia. Our loops decrease our calcium, get rid of it, hypocalcemia. The thiazides are going to prolong our QT interval. Okay. Potassium sparing is sparing our potassium. So make sure that you check their potassium. And so taking a ACE inhibitor and potassium or an ARB and potassium is probably contraindicated. Sometimes you'll see it in the hospital, but You just have to make sure that their potassium's okay. You don't want to take that with potassium supplement. Okay. Pharm of fluids. Okay, so things to know is like drugs to treat hyperkalemia. Remember calcium first, D5, and then ringers. So I'm going to skip again to the end. Okay. So drugs causing disorders, hyponatremia, if we try to fix it too quick, low to high, lungs will die. So brainstem herniation. Drugs treating hyperkalemia, again, we want to stabilize the myocardium with calcium gluconate before we do anything else. Next, then we're going to shift it with bicarb or insulin, albuterol. And remember, insulin goes to dextrose so that our glucose is not too low. IV fluids, D5 helps with free water. So this can be given in severe hypernatremia and can replace the ECF volume first. If you need to fill the vascular volume to replete, so somebody's dehydrated, you can give them LR. Okay, and these were some practice questions that she gave. So you see the EKG, you see the T waves. What do you first give them? You give them calcium again. And what is the mechanism? It's activating the GS. So I would just like to know that. For the mechanism to shift our potassium in. What fluid provides the most water to the intracellular compartment? It's going to be our D5. And then, so it's going to, again, let me flip back one. Our D5 is going to be our free water. And then a 72-year-old male nursing home patient is hypotensive, tachycardic with a fever. His mucous membranes are dry, cap refill delayed. So we're thinking he's dehydrated. What should we treat him with initially? We just want to replenish him, so we're going to give him some lactate ringer. All right, I got a few more questions. All right. You watched a late night crime TV show after your last OPP, EPZ, LNOP exam. A woman was poisoned, a woman was poisoning her husband with antifreeze in his Gatorade. Uh-oh. You know that what types of crystals are in his urine? This is the easy one. I tried to trip you though. Okay, good job. Calcium oxalate, not calcium phosphate. Okay, let's go to our next one. Question 7. Fred is a 94-year-old male that has a BUN of 60 and a creatinine of 3.1. What could cause his kidney issues? Tubular damage, dehydration, or a big prostate? All right, let's see what we got. Okay, good. So let's talk about this. We need to look at our BUN creatinine ratio. So if we take 60 divided by 3, we pretty much have a 20-to-1 ratio. It doesn't have to be perfect, so don't worry about that. So if we have a ratio 20-to-1 or greater, that is going to be pre-renal. So pre-renal is going to be dehydration. If we have a ratio between 10 to 1 or 20 to 1, that's going to be I think of like in the kidney issue. That's actually going to be your next block when you talk about all the kidney problems. Nephrosis, nephritis sort of thing. So that would be like maybe tubular damage. A post-renal would be less than 10 to 1. And that's going to be something like an obstruction. So I put like big prostate. So the answer to this one, we have 20 to 1, is going to be our dehydration. Question 8. I get a urine back and it's got 4+ protein on dipstick, and the micro has oval fat bodies. What is in it? Or what is it? All right, let's see what we got. Okay, so if we have a ton of protein, this is important to know between nephrotic and nephritic. If we have a ton of protein, that's going to be nephrotic. If because it's greater than 3+. Nephritic is going to have, it can have some protein, but it's going to be lower. It's not going to be above 3. And then it's going to have red blood cells as well. But the main thing here is that 4+. And then the oval fat bodies can help you as well with that. Okay, we get another urine back, and it's got 1 to 2+ blood with dysmorphic cells and RBC cast. What is it? Okay, so here's our nephritis. It's our glomerular nephritis. So remember ethylene glycol, we're going to see those calcium oxalate stones. A UTI, we're going to see white blood cells. Kidney stones, we're not going to see red blood cell cast or dysmorphic cells. We're just going to see regular red blood cells. Okay, we've got 3 more questions. Question 10. Bunny has been running a marathon yesterday. Today she noticed this red urine. You look under a microscope, but you don't see any RBCs. What's her issue? I'll even give you this, which makes it more confusing. On the dipstick, it says she's got red blood cells, but the microscopic says none. All right. We'll end our poll. So we've already talked about glomerulonephritis. We already talked about kidney stone. That's what urital calculus is. Nephrotic syndrome we've already talked about. So what are we left with? Rhabdo. So basically there's going to be, you might also see an increase in our creatinine kinase. So we're going to have a breakdown of muscle. So she's running a marathon. That could be part of it. So that might be something you might see in a question. So it's being broken down. So there's going to be on the dipstick, it's looking for the hemoglobin itself to tell it it's positive. But on the microscope, all the red blood cells are broken apart, so you won't see anything. So it's rhabdo. Make sure you know that. Question 11. Patient has metabolic acidosis. Her potassium is 2.5, which is low, and a urine pH of 6. Which tubule is our dysfunction? Oh, I didn't launch it. Okay. Good job. It's our type 1 RTA, so it's going to be in the distal tubule. So the proximal tubule is going to have a low pH and low potassium. Our collecting duct is going to have low pH and high potassium. Okay, last question. Refeeding syndrome can result in what imbalance? Okay, good job. It's going to be low phosphorus, so we'll have hypophosphatemia. All right, so as promised, I have this some thoughts before your exam, and I'm going to post this into my Google Drive, and this should help you out a lot. And then just practice on those acid base. If you have any questions, feel free to message me or ask me anything.